Okay, we are discussing about replacement with IV potassium chloride. Now, peripheral route, it is safe. It is used in mild to moderate hypokalemia. That is when the potassium is 3 to 3.5 milliequivalent per liter. 20 to 40 milliequivalent per liter of KCl is added to each liter of fluid given over 4 to 6 hours. A saline rather than dextrose solution should be used. Half-strength saline with 20 milliequivalent of KCl makes the solution isotonic and suitable for peripheral use. Do not use high concentration over 60 milliequivalent per liter. It can lead to pain and necrosis of peripheral vein. Volume overload is a potential risk in the susceptible patients. Now, central route. Prepare 20 milliequivalent of KCl in 100 ml of normal saline or half-strength saline. 5 to 20 milliequivalent through the syringe pump can be safely given by central route, preferably femoral vein. Life-threatening arrhythmias. Up to 40 milliequivalent of KCl can be given for few hours. No other infusion should be going through the same catheter. This is very important. Avoid the blood sampling and flushing the catheter. Frequently monitor the potassium till it is 3 to 3.5 milliequivalent per liter. Continuous ECG monitoring is required. Step 5. Replace the IV magnesium. Hypomagnesemia is usually concurrently present with hypokalemia and needs to be corrected. This is an important point which is often missed. Step 6. Ascertain the cause of hypokalemia and manage specifically. Detailed history and physical examination should be performed to look for systemic causes of hypokalemia. History of increased urinary or gastrointestinal loss of fluid, such as in vomiting, diarrhea, polyuria, should be taken. Detailed drug history to rule out the drug-induced hypokalemia should also be taken. Urinary potassium level of more than 30 milliequivalent per day is a feature of loss of potassium in the urine. Step 7. Send investigations. Complete blood count, sodium, potassium, calcium, magnesium, phosphate and bicarbonate. Urea, creatinine. Creatine phosphokinase, that is CPK. Arterial blood gas analysis, ECG. Now coming to the causes of hypokalemia. Increased entry into cells, metabolic alkalosis. This occurs in metabolic alkalosis or initial phase of decay, that is diabetic ketoacidosis. Elevated beta-adrenergic activity. So these are the steps of administration of beta agonist. Hypokalemia, that is causing periodic paralysis. Hypothermia, chloroquine intoxication. Others like vomiting, diarrhea, tube drainage, laxative abuse, increased urinary losses, diuretics. These all causes loss of potassium. Primary mineralocorticoid excess. Hypomagnesemia, amphotericin B, salt wasting nephropathies, including Barter's or Gitelman's syndrome. This is salt wasting nephropathy. Renal tubular acidosis, like polyuria. Increased sweat losses, that is dialysis, plasmapheresis, decreased potassium intake. This is rare cause. Other investigation you have to send is urine for potassium and urine analysis. Step 8, that is replace the potassium orally. Once serum potassium has been raised to a safe limit of above 3 milliequivalent per liter, the rest of the replacement may be done slowly by oral route. This could be achieved by adding potassium-rich diet, potassium salt or potassium chloride suspension. Treatment is usually started with 10 to 20 milliequivalent of potassium chloride given 2 or 4 times per day, 20 to 80 milliequivalent per day. Now we come to the step 9, reduce the loss of potassium. In patients with hypokalemia, due to increased urinary losses, potassium sparing diuretics such as spironolactone, amiloride or eprinone may be needed. The last one is not used very much. Oral or IV potassium should be used with caution. In these situations, especially in patients with impaired renal function. Now we come to the end of this session. Next session I will come with the remainder of today's lesson. Thank you.